So first of all, I hope everybody's okay. We'll just go by first names.
Yeah, absolutely.
Try to be a little bit informal here because you guys get to sit on couches while I have to stand. So what we'll do is we'll do this kind of like a tumor board style. I have a couple of cases I'd like to go through and we'll ask some questions. And at the end, I also want to give an opportunity for people to ask questions in the audience as well. So we'll try to get through these cases over the next 30 minutes relatively quickly. So the first case I want to present is a patient with rectal cancer. So this is a 33-year-old female who was diagnosed with a T3N2 M0 mid to upper rectal adenocarcinoma. And then there was some question of some circumferential margin positivity on her MRI. She's 33 years old and she's still interested in fertility. And so a couple of questions that we can kind of start out with. So we now know that in rectal cancer, the TNT approach is kind of now standard of care, meaning starting with neoadjuvant chemotherapy and radiation. But the question I have is, and I'll start maybe by asking Van, how do you decide on what order to start the total neoadjuvant therapy, whether to start with systemic chemotherapy first versus starting with chemo radiation?
Yeah, it's a good question. And we do it kind of on a case-by-case basis, though, with a multidisciplinary kind of tumor board at our institution. To answer the first question, yes, we absolutely would do a TNT approach kind of for this. And certainly the data with the Rapido trial kind of coming out several years ago showing short course followed by doublet chemotherapy, the Protease 23 trial, which looked at FOLFOXIRI and long course radiation prior to surgery, chemo radiation prior to surgery, and then the Oprah trial as well. You know, that was a phase 2 trial, but that looked at upfront chemotherapy followed by chemo radiation versus chemo radiation followed by chemotherapy. And in the Oprah trial, again, a phase 2 trial, it comes with its limitations, suggested that upfront chemotherapy followed by consolidation chemotherapy, you know, in that particular study, you know, those patients may fare better in terms of, you know, long-term disease outcomes. So I think kind of at our institution in general, we prefer the more of the Rapido approach, and that's been the one that we've adopted at MD Anderson, which is the short course followed by the consolidation chemotherapy.
Thank you. That's a great answer. One of the questions that's not on here was maybe more aimed at Aimee. This is a young patient with a colorectal cancer, and we know we are definitely seeing more patients being diagnosed at younger ages. How does genetic testing kind of play into how we're going to treat this patient and also how we counsel a young patient like this?
Great. Yeah. So a patient this young, you would be concerned that there could be some sort of underlying genetic predisposition for developing colon cancer. So oftentimes we'll do tumor testing, and I'm sure we're going to get to that in the next slides, but we'll do tumor testing to see if the patient has any deficiencies in mismatch repair. But let's just say this patient doesn't have anything like that, doesn't have Lynch syndrome. There's a lot of data recently that suggested patients diagnosed under the age of 45 with colorectal cancer can have a pretty high possibility of having a germline mutation. And it may not necessarily be in a Lynch syndrome gene or a gene that you might expect. You can have mutations in DNA repair genes and other things. So definitely someone at this age you'd want to refer for genetic counseling.
Thank you. That's great. Yes. And so along the same lines, one of the things that we've been noticing in patients with colorectal cancer and many studies that are kind of upcoming is trying to maybe de-escalate therapy in some of those patients. You mentioned the Oprah trial and trying to go to non-operative management. But this is a patient who is 33 years old and is very interested in fertility and may want, and we know with radiotherapy to the pelvis that we're going to definitely affect fertility. Assuming that we start with induction chemotherapy and this patient has an excellent response to chemotherapy, would any of you consider not offering, I know I'm the radiation oncologist, but would any of you consider not offering radiation to this patient and taking her straight to surgery, off trial, for example? Let's start with that.
I would not.
Yeah. So, Yeah, that's actually an ongoing question of a trial that is now closed to accrual called the Prospect trial. We don't have the results of the trial, and word on the street is that's a good thing because they don't have enough events yet to actually publish. So maybe in the future that will be an option, I think, for patients. But I agree that right now I think there's just not enough data to support avoiding that.
I would just say as well, in the case of this particular patient, I don't think that she even would have been a candidate for the Prospect trial because if I remember correctly, an N2 status was not included in this. So she, even irrespective of the Prospect data, which is very exciting and greatly anticipated, this wouldn't even be a candidate for that because of her N2 status.
That's a very good point. One other comment on preserving fertility, there are other ways to preserve fertility even when offering patients radiotherapy, and some of our GYN oncologists have helped with things like ovarian transposition and other types of ways to preserve fertility, but that's a very important discussion to have with the patient at the onset of treatment. So, same patient, but this time they were found to be MSI high. So we and they were found to have a lack of MLH1 with a BRAF V600 negative tumor. So what type of genetic testing would we offer this patient?
At a minimum, you'd want to offer patient testing for Lynch syndrome, but most people are now offering some form of a multi-gene panel for patients. While you see this particular profile, deficient MLH1, absence of BRAF, is in a 33-year-old is highly suggestive of Lynch syndrome. It's not necessarily diagnostic. You can also, it will suggest a high likelihood of finding a germline MLH1 mutation, but in some cases you can find PMS2 mutations. In very rare cases, mutations in other genes can potentially affect mismatch repair, so biallelic MUT-YH mutations can sometimes have downstream effects causing biallelic somatic mismatch repair mutations, the POL-E, POL-D1 genes. So again, you want to make sure that you're doing at least a colorectal cancer panel or some sort of comprehensive panel.
And again, this question I guess is for Van, who alluded to the data that we saw at ASCO GI this year. Would you, again, just kind of showing that data again with the 11 patients having a complete clinical response to immunotherapy alone, off trial, are you offering immunotherapy to patients with MSI high rectal cancer?
Yeah, I mean, I think just to kind of take a step back, with the more wide acceptance of total neoadjuvant therapies, patients understandably, when they're diagnosed, want to do everything they can to avoid a permanent colostomy. And that is very understandable. So if immunotherapy represents what appears to be a very viable path towards a potentially curative approach. Without that, we definitely are having this discussion to this patient. I would say, I'm mic'd, but off the record, yes. But we really want to get these patients on clinical trials like Dr. Sion-Bors and really show this definitively. I will say that in our locally advanced MSI high colon cancer cases, we can have patients who we know are having clinical responses. We can see, improvement in resolution of their anemia, like things like that, to suggest like this tumor is melting away. I think, depending on the surgeon at our institution, they still will say, we feel the standard is still surgery for this patient. So I think we need the data to really definitively show this. But yes, more and more we're having this conversation.
Yeah, and as a radiation oncologist, I also, off trial, I would not be very comfortable not offering these patients radiotherapy in the neoadjuvant setting. On trial, I would love to open a trial and look at that, but I think off trial, we still need to give these patients standard of care.
Sorry, Noam, if I may mention just 2 points. So I think it's important to recognize as we transition immunotherapy to the neoadjuvant setting, we're capturing a bigger swath of patients, right? So MSI high metastatic colorectal cancer only represents 5% of the overall population. When we're looking at more localized settings, we're looking at 20 to 25% of disease. And so I think that's quite relevant because we're capturing that group in a greater sense.
That's a really good point, thank you. So, again, I guess is another question for Van. So let's assume that the patient is now past their therapy and either they've had their surgery or they're within their non-operative management. Is there any role for ctDNA monitoring in these patients?
Yeah, I think there is. I think especially if they're going for watch and wait and non-operative management, we really are trying hard to incorporate ctDNA testing into the surveillance of these patients. You know, how would we intervene? I mean, I think that's the question if it were to turn positive. I think for me, it would give one additional data point, if negative, that we can rest assured that this patient likely is going to have a very good long-term outcome. You know, if positive, we're really going to just, ratchet up how close we're following these patients. You know, are they meting out or is it going to be a local recurrence?
Absolutely. Well, thank you. Okay. So moving on to the next case, and try to get our hepatobiliary guys a little bit more involved, sorry. So this is a pancreatic cancer patient who is 72 years old with a locally advanced pancreatic cancer with an initial CA19-9 in the 2000 range. So the first question I have, and I guess this is more a question for Dr. Dickson, for Paxton, sorry. What is the role of surgery for locally advanced pancreatic cancer? So traditionally, when I was in medical school, everybody talked about these being unresectable. And now I've been taught that we should never use the word unresectable. So what is your feeling on the role of arterial reconstruction type surgery in patients with traditionally locally advanced pancreatic cancer?
Limited. To put it in one word, and I've never told you that something's not unresectable. Yeah. I think that the resectability of pancreatic cancer is really a spectrum. And we try to define it based on anatomy, particularly with tumor relationship to critical vessels, and performance status and response to neoadjuvant treatments. And I think that we're now in an era where with relative routine performance of venous resection and reconstruction, SMV portal vein, for the traditionally defined borderline resectable pancreas cancers. But once we start to see critical arterial involvement, particularly superior mesenteric artery involvement or celiac involvement, I think that the role for surgery in those patients, they are at the bottom of a very tight funnel. Yeah. I think they have to have really, because the morbidity of these operations are significantly higher. And, and we're still looking at a patient population who we know is likely going to recur in less than 3 years. And so the question really has to be, are we providing them a meaningful survival benefit and an acceptable quality of life during that survival? And so I think major arterial resection and reconstruction, although it is being done, and in some centers more than others, it has to be highly selected, heavy preoperative therapy with good evidence of systemic response, and highly educated patient who knows what they're getting into, and an acceptable performance status.
Yeah, that's a great answer, and I think you hit all of the points that we usually bring up at Tumor Board. So assuming this patient is not going to ever go for therapy, performance status is not terrific, a 72-year-old, we usually, again, would start with systemic therapy for the systemic cancer. Satya, which chemotherapy regimen do you generally like to start with, and how do you make your decision between the standard chemotherapies regimens?
Yeah, and if I may, for just the first point too, I'd be highly concerned for micrometastatic disease in this patient. So Paxton would do a diagnostic lab before the port, and likely with that degree of CA19-9 elevation, we'd find some disease there. With regards to chemotherapy, is quite relevant actually, and actually, as with anything in oncology, tissue is the issue, and so sometimes we don't have adequate samples. Many of these patients are diagnosed on fine needle aspiration, so we actually are doing NGS testing from ctDNA to look for the presence of actually DNA damage repair mutations, because that does influence the choice. There's some really nice data from the Know Your Tumor database and Mike Pishvayan's data looking that if patients have DNA damage repair mutations, particularly BRCA, but others as well, and we can touch on that in a little bit, people do better if they get platinum-based therapy. And it's interesting, we always think about FOLFIRINOX being a platinum-based therapy, but there's another regimen too, gemcitabine and cisplatin. And so Eileen O'Reilly's group had presented data. This was mostly metastatic patients, but 16% had locally advanced disease. These were all patients with BRCA germline mutation, as well as PALB2 mutations, although I think the majority were BRCA. And patients received gemcitabine and cisplatin, or gemcitabine, cisplatin, and the PARP inhibitor veliparib. The PARP inhibitor didn't do anything, but gemcitabine cisplatin elicited a survival time of almost 16 months. So we certainly think about, if this patient had a DNA damage repair defect, gemcitabine and cisplatin would also be a reasonable consideration.
Yeah, that's a great point. And that actually takes us to our next question, which is germline testing in these pancreatic patients. Aimee, are you recommending germline testing in all pancreatic cancer patients?
Yes, we are. We have been since probably early 2000, and that's just because multiple studies through multiple institutions have shown that anywhere from 4 to 10% of patients or unselected pancreatic cancers can have underlying germline abnormalities, which can have really important implications for treatment, as in BRCA1, BRCA2, possibly other DNA repair genes, and then of course really important implications for the family as well.
So are we doing the larger panels on these patients, or are we really just checking BRCA1, BRCA2 in most of these pancreatic patients?
We're doing larger panels as long as we can get insurance to cover that, and usually we don't have a problem. But yeah, typically the most common mutations you're going to see are in BRCA2, followed maybe by ATM, BRCA1, and Lynch syndrome genes as well.
Yeah, and I guess I take that question back to Satya. Are you only changing your recommendations for systemic therapy on BRCA mutations, or are you changing things based on other homologous recombination repair?
Yeah.
And sorry. Yeah.
Yeah, it's a great question. I think it's a really good question. I think the strongest data for modifying therapy, whether, for example, in the metastatic setting, right, olaparib is now approved as a maintenance drug for germline BRCA mutant pancreatic cancer patients, metastatic or unresectable, who haven't progressed on platinum-based therapy. The question of whether somatic BRCA mutations are actionable is hotly debated. I think the data is less striking. I think it actually has to do with functionality. So if you actually have loss of function, even a somatic BRCA mutation can be pathogenic. We tend to look at other things too. So for example, ATM mutation loss, and again, loss of function in ATM predicts responsiveness to ATR inhibitors, a number of which are in the clinic. And so that is something that's highly relevant for us as well. But I think really at this point, we're intervening per se on BRCA mutations, and particularly loss of function, which is mostly in the germline setting.
Great, thank you. So this patient actually was started on Gem/nab-paclitaxel and actually did very well. You can see here, this is how his CA19-9 came down over time. It's hard to see the actual numbers here, but the blue line is going down. So he was reevaluated by a surgeon, and it was still felt that he was not a surgical candidate, both anatomically and performance status-wise. So I kind of got to that already. So the surgeons already said no. And so I guess the next question I have for the board is, what would be the next step for this patient after 5 to 6 cycles of Gem/nab-paclitaxel? Would we move towards a more local therapy? Do we continue chemotherapy? How long do we continue chemotherapy? And we kind of already addressed a little bit the role for olaparib. Any thoughts?
Yeah, I was going to say, I think definitely, and I think it varies a little bit based on institution, but we certainly think about consolidative radiotherapy in some capacity, if for the very reason to give a patient a treatment break from systemic therapy. So I know the randomized study, the LAP-07 trial, looked at patients after 4 months of gemcitabine and randomized them to chemoradiotherapy with capecitabine, I think to 54 gray, or continuation of gemcitabine alone. And there was no difference in overall survival, but there were two interesting endpoints that were significantly improved, which was time to local progression, or rates of local progression. It was 30% in the chemoradiotherapy arm versus almost 50% in the chemo alone arm. And then time to subsequent therapy was 6 months in the chemoradiotherapy arm compared to 3 months in the gemcitabine alone arm. So I think it definitely is certainly something to consider.
Yeah, and so at least at West and in our institution, the feeling is that yes, these pancreatic cancers are definitely systemic diseases, and but as our systemic therapy has improved, so has the need for local therapy as well. And so, we did recommend definitive chemo radiation in this patient. We now use a method where we give ablative doses of radiotherapy, but we fractionate them, and this is kind of based on data that was published in JAMA Oncology and some previous data from both MD Anderson and Memorial Sloan Kettering and Chris Crane's group, which showed really, I wouldn't say excellent, because nothing in pancreatic cancer is excellent outcomes, but improved outcomes from what we would normally have seen in this patient population with 2-year survivals of the 38% range. But I do want to point out that even with these very high doses of radiation, there still is about a 33% local failure rate. Because we know that some of these, unfortunately, some of these patients just have tumors that are not responsive. And in addition, it's hard to get very high doses into this area where there are a lot of luminal structures. So just to show you, I'm going to show off a little bit because I'm a radiation oncologist. So just to show you, this is the plan that we came up with for this patient. And as you can see, we're actually going to 75 gray in 25 fractions to that kind of red volume at the center of the tumor, which is also thought to be probably the area that's the most hypoxic and probably needs the highest dose. But as you can see, very important luminal structures kind of surround that, including the duodenum and the small bowel and the stomach. And so the surrounding area gets about 45 gray. And in that way, we can try to give as much dose as we can, and hopefully, give a very high dose to the most necrotic area. And then this patient, I can't tell you the outcome yet because we're just starting him. But so far, our experience has very much mirrored the experience that was published from MD Anderson, Memorial Sloan Kettering. And one thing that I will say that is relatively nice about this treatment is that patients tolerate the treatment very well. And so I think, as Satya had said before, at the very least, we're giving a patient a break from systemic therapy. One argument I've heard is, well, why not just send them on a cruise? But at least this is a break that is, it's a break from systemic therapy, but at the same time offering patients the possibility of long-term control with very little toxicity. So that's kind of what we have been doing here at West. Thank you very much to our speakers and to our panelists. I think this was a great session. Thank you.
Thank you.
Appreciate it.